Good afternoon, everybody, and welcome to our webinar this afternoon with the Corporate Mental Health Association Alliance of Australia, with Metluma and with Deloitte. We have many people with us in the room and many more with us on Zoom today. I'd like to start by acknowledging the traditional owners of the land in which we meet today. In Sydney at the Deloitte office, we're with the Gadigal people of the Eora Nation, and I'd like to pay my respects to elders past, present and emerging. My name is Karen Stain. I'm a menopause champion and I lead the menopause working group for Deloitte. And we're very excited today to be hosting this fabulous webinar with the topic Women's Hormones and Mental Health, What We're Missing. It's very fitting that we're having this session today, being in October on World Menopause Month. There's a lot that we need to consider for employees and organisations when we're trying to give them support through different life stages. And certainly at Deloitte, we've worked hard to try and support our workforce through this life phase. It's recognised that many of the symptoms that come with perimenopause can impact how we think, how we feel, and how we function. And so having the conversation today is most certainly going to be in support of that. When we're looking at how we can assist people with thriving through this life stage, we've provided a number of practices and guidelines for our workforce, including flexible work practices, workplace adjustments, group coaching for managing menopause, and of course our menopause cafes, which in fact we'll be hosting next week for World Menopause Day in our offices nationally. Now we're trying to assist our workforce with being able to feel much more confident, much more competent and much more connected. And having conversations like we are today takes us another stride forward in doing just that. We're also very proud of the work we've done here and how it's been recognised by Menopause Friendly Australia. We're the first employer in Australia to be accredited as menopause friendly, and we're very proud of that. We're also proud of the association that we have with the Corporate Mental Health Alliance Australia. In coming together and teaming, we know today we're going to be provided with many more insights which will build our awareness and understanding of how we can be in support of ourselves through this life stage, but also how we can be in support of others, our family members, our colleagues, and our friends. We have an esteemed panel who'll be sharing with us their insights, their wisdom, their knowledge and research. And I'd like to introduce to you Dr. Kim Hamrosi, the CEO of the Corporate Mental Health Alliance Australia, who'll be facilitating the panel today. The Corporate Mental Health Alliance Australia is a business-led, expert-guided organisation committed to creating mentally health workplaces across the country. Kim brings over 20 years of experience in healthcare, spanning clinical pharmacy, academic research, health economics and large-scale strategy and implementation across government, industry and the not-for-profit sector. As CEO, Kim leads a national alliance of some of Australia's largest employers, working together to drive systemic change in workplace mental health and wellbeing. And I'll pass over to Kim and invite Kim to also introduce our panel members, Associate Professor Caroline Gurvich, who's with us on Zoom or on Teams there, Dr. Nicole, Avard and Melinda Upton. Thank you.
I think there's a bit of a technical glitch at the minute, which I think we're trying to solve. As I understand, people can't see the room. Is that right? Can they hear us? Can they hear us?
Yeah, they can see Caroline.
Okay, well, for the minute we're going to be starting with Caroline. So, bear with us. It's fixed. Great. Thank you very much, everyone, and thank you to Deloitte and Metluma today as well. Deloitte for hosting. Thanks so much, Josh. There's always a technical glitch. I always find that we can never go without some sort of hybrid. It's a testing thing, and you know we've stayed cool.
You have technical resilience.
Exactly, technical resilience. Firstly, I'm going to say thank you to Deloitte once again for hosting today's event and for everyone who's attended in person and online. We've had enormous interest in today's session, and it will be recorded, and we will be sending around a short resource and a copy of the recording for those that registered. Feel free to share that then with anyone that you know that may be interested in today's topic. So I'm going to start off by introducing our wonderful panel. Firstly, we have Caroline, who's joining us online from Melbourne. So Caroline is Associate Professor at Monash University and a clinical neuropsychologist, leading research at the intersection of cognition, hormones and mental health. As Deputy Director of the HER Centre, Australia, and the head of the cognition and, I'm going to have to take my glasses off, I can't see. I was hoping to be able to cheat. And hormones group, she combines neuropsychological assessment with eye movement research to deepen our understanding of how biological factors shape mental health. With over 100 publications and multiple research grants, Caroline is also a passionate mentor and a strong advocate for gender equity in science. So welcome, Caroline, to having you today. We're pleased that you're here.
Thank you for having me.
Excellent. And we also have Dr. Nicole Avard, is a general practitioner with over 25 years of experience in primary care and is deeply committed to patient-centred care and women's health. She is the co-founder and medical director of Metluma, a pioneering digital health initiative supporting women through menopause. Her incredible work reflects a passion for innovation, collaboration and empowering women to take charge of their own health. Welcome. And finally, the fabulous Mel Upton, who is from Deloitte. Many of you have known Mel for the last few years since I've been involved with the Corporate Mental Health Alliance. And she brings over 25 years of global leadership experience in intellectual property, technology strategy and corporate performance. Having held senior roles at leading law firms and now in her current role at Deloitte, Mel is known for helping organisations navigate complex legal and business challenges. More importantly, Mel is a passionate advocate for mental health, and she chairs the Minds Count Foundation, and she has served on several boards, including our CMHAA board, and she's absolutely dedicated to improving workplace wellbeing. Welcome to everyone.
Thank you.
So today we're diving into a vital topic that, let's be honest, that affects roughly 50% of the population at some point in our lives, and that's menopause. While it's an entirely natural phase of life, the experience can vary wildly for women. Some might sail through with hardly a bother, lucky them, while for others, symptoms can be pretty severe and often debilitating. We all hear a lot about the infamous hot flushes, and I know I teased my mother mercilessly at the time until I experienced them a few years ago, and so I'm far more compassionate. But what we're actually going to focus on today is that there's so much more going on for many women, particularly concerning their impact on cognition and mood. This area, specifically the cognitive changes and the links with depression, things like brain fog, word finding issues and forgetfulness often seem to be less understood and not as openly discussed. Many women and even employers currently lack understanding of menopause's mental health effects, such as these low mood and cognitive impacts, which are frequently mistaken for other issues. In fact, there's a noted tendency for depression during perimenopause to be misdiagnosed and treated with antidepressants instead of considering HRT, which could have potential impacts on women's health and well-being. So today we'll be exploring the critical intersections between hormonal changes, cognitive shifts and mood issues, aiming to improve education, challenge the stigma and foster the much needed positive and open conversations in our workplaces. So I'm going to start with a big picture question, looking at the science, and then we're going to zero in on what we can do about it. I'm going to start with you, Caroline. Welcome again. Can you explain to us how hormonal shifts and brain changes during perimenopause and menopause cause those common cognitive issues many women talk about?
Yeah, it's a great question to start with. And I think we often think about our reproductive hormones controlling our reproductive functions. But the hormones we're mainly talking about are estrogen and progesterone, and they do a whole lot more than control reproductive function. So they travel across the blood-brain barrier, they enter our brain, and we have receptors in our brain that respond to changes in these hormone levels. So during perimenopause, there are quite rapid fluctuations and a gradual decline in one of our estrogens, estradiol, and our progesterone's declining. And the areas of the brain that respond to these hormone changes are the front part of our brain that's really important for our higher order cognitive skills, our executive functions, so things like planning, organising, decision making, as well as another area of our brain that is in our temporal lobe, and that part of the brain is also very important for other thinking skills like our memory, and also regulating our mood, our emotion regulation. So this is kind of the science behind why hormone changes, estrogen and progesterone changes, might have an impact on our brain, and in particular impact brain areas that are really relevant for thinking skills and how we feel. And another important piece of science is that these hormones, they're quite potent neurosteroids in the brain, which means they interact with other chemical transmitters in a brain. So people might have heard of dopamine and serotonin. These are neurochemical or neurotransmitter pathways in the brain that are also really important for mood and for regulating things like our motivation and our cognition, our thinking skills. And so these hormones also play a role in modulating or changing different aspects of these chemical pathways in the brain. So there's lots of science behind why reproductive hormones and changes in reproductive hormones, which is what happens during perimenopause and menopause, can then have a flow-on effect to impacting our thinking skills and our mood as well.
Can I ask you to expand a little bit more around the things like brain fog and the forgetfulness and finding it hard to find the right words? I know I had a conversation just here in the room earlier about those moments where you are thinking you are losing your mind and you are perhaps got early onset dementia or something, because you're starting to be worried about the fact that you're losing some of these cognitive abilities. Can you tell me a little bit more about that and what we can actually do to tackle that, because it can't be all bad, I'm guessing, I'm hoping.
Yeah, of course. So many women talk about this experience of brain fog. So brain fog is like this lay term, and it includes lots of different thinking skill changes that people talk about. So it might be, that tip of the tongue phenomena, just can't find the right word. For some people, it's lapses in attention and concentration. Some people describe it as a mental fatigue or a challenge making decisions. So it can be a whole range of different cognitive symptoms that about 2/3 of women can experience during the menopause transition years. And when we're talking about the transition years, that perimenopause, for some women, that's sort of up to 4 to 10 years. So it's a long time, and it's not severe for everyone. So some people might just have fleeting moments where their cognition isn't as sharp as they felt it might have been. But for some women, it's quite significant and really very bothersome and disturbing and anxiety provoking. So it's a whole range of different levels of severity for the brain fog symptoms. And they can be caused by, we think, by lots of different things. So the hormone changes are probably one of the key contributing factors, but all the other experiences that people have during menopause, like poor sleep or pain or depression, anxiety, irritability, all of the symptoms that people can experience during menopause might also have another indirect effect on cognition. So there can be lots of reasons as to why people experience brain fog. But one thing I always like to remind or talk about is this subjective experience of brain fog. It's very real, but when we do neuropsychological assessments and really drill in and assess people's cognitive capacity, that generally doesn't change significantly during menopause. So you mentioned the am I losing my mind? Is this dementia? Is this ADHD? They're often questions that people ask clinically, but the core cognitive abilities that people have don't change. So in dementia, like dementia of the Alzheimer's type, people do lose their capacity to learn and recall new pieces of information. That core cognitive skill does change and diminish and gradually decline. That is not what happens during menopause. During menopause, people experience this brain fog, and it can be bothersome, but their ability to use their intellectual skills and their cognitive skills generally doesn't change. So that's hopefully reassuring to people to know that it's not that people's cognitive capacity changes, but there is this very real day-to-day experience of challenges, and they might fluctuate across time. In terms of what people can do about it, a lot of things. So there is help. Don't just sit there and suffer. Firstly, I think just validating, having these conversations and knowing that it's a really common experience. Sometimes that can just be reassuring for people to know that they're not experiencing something very odd or unique. It's very common to have brain fog during menopause. So that kind of validation can be one thing in these kinds of conversations. Then trying to speak to your healthcare provider or going through Metluma or whatever to have a look at what you can manage. So if it is poor sleep or other symptoms that might be indirectly impacting your cognition, you can often do a whole lot to manage all of those things. So that's another thing that people should do, is try and seek help so they can manage whatever symptoms they can manage. And then the practical things people can do is to try to reduce how much information you're juggling in your working memory. So that our working memory, which is when we kind of hold and manipulate information in our mind, juggle thoughts, that's capacity is limited. There's only so much we can ever hold and juggle in our mind. And so if you're really busy and your life is very full, sometimes we're holding on to lots of pieces of information in our mind, and that is often when we experience more of these challenges with our cognition. This is for anyone at any point in their life, but for women going through menopause, are often at a really busy time of life, so there's a lot going on. So really practical things are things like writing down as much as you can, using diaries, calendars, electronic reminders, things like that, to try and get information out of your head so you're not juggling a whole lot, and get it onto paper, having structure, routine, taking notes in meetings, using any kind of digital tools that you can use to reduce the demands that you're placing on yourself, on your working memory. And that can help kind of free up some space and really maximize people's cognitive skills that they still have, but just might need a bit of structure or scaffolding to support their cognition during those menopause transition years.
Well, I think all women juggle a lot in their brains every day,
yes.
especially as you get to that sandwich generation where you're looking after kids and potentially elderly parents as well. So I do have a quick question you just touched on about, potentially being other things like ADHD or early onset. What about the depression piece? How do we know that, what should we be looking for in terms of determining whether it is possibly a menopause thing or a perimenopause thing, or it is genuine depression?
Did you want me to take
I'm happy if you want to start with that for you, and then I'll call the practical aspects of this as well.
Yeah, sure. So I think it is about speaking to someone who can help you tease apart what symptoms you're experiencing. Each of those things, so depression and brain fog and ADHD and early onset dementia or young onset dementia, they all present quite differently at a clinical level, and they can coexist. So none of those things can happen. It has to happen independently either. So in terms of depression, the depression presentation that can happen during perimenopause, it can be slightly different to a clinical depression that can happen at different stages of someone's life. And it can be a little bit more, sometimes the symptoms can be a bit more on-off, and sadness might not always be the most prominent symptom. So it might be irritability or rage and paranoid thinking. So those kinds of symptoms aren't always associated with this clinical depression at other points in people's lives. So it can present a little bit differently and, a little bit more on-off. So people can feel okay and then feel really not okay. And so, again, exploring the symptoms that you're experiencing, taking note of them and talking to a healthcare professional about the symptoms you're experiencing is really important. So if you're suffering at all or questioning or concerned at all about your mental health, your mood, I would strongly encourage someone to speak to a healthcare provider about how they're feeling. With ADHD by its diagnostic criteria is something that symptoms emerge. It's neurodevelopmental. It's a brain type. It's been there prior to the age of 12. So if someone has starting to experience symptoms of inattention, which might be part of the ADHD presentation, and then new onset, they've just been experiencing those symptoms during the perimenopausal transition years, and they've really had no symptoms at all or no characteristics of ADHD prior to those years, it's unlikely to be ADHD, because by definition, there has to be some evidence of symptoms prior to the age of 12. However, for some people, they've kind of coped and managed to handle their ADHD up until a certain point, and they get to those perimenopausal years, and it kind of uncovers something that's always been there, because they're at a point that they're super stretched, like we were just talking about, and the coping mechanisms that they've been using for many years just don't cut it anymore. And perhaps the hormone changes, estrogen interacts with dopamine, which is really important in ADHD. So there might be hormonal mechanisms that might exacerbate ADHD. There is literature that ADHD gets worse for women during perimenopause. So for all of those reasons, sometimes there is an ADHD that's always been there, and it gets to perimenopause and it's just heightened, uncovered. And again, there is support and help out there for people who are really struggling. And with the early onset of dementia, just by age, most people, when they're in their perimenopausal years, it's just generally not young onset dementia. So dementia is generally diagnosed over the age of 65. Before that, it's young onset, and it's quite rare. And young onset in the around the age of 50 is even more rare. So just by the people's age, it's really unlikely. However, it can happen, but very unlikely. And the difference is with dementia, the symptoms, particularly young onset dementia, are quite different to menopause. So they're quite profound. Memory changes, there can be behavioural changes, mood changes, a whole range of different symptoms that when you see someone who works in this space, they'll quite easily be able to tease it apart and generally reassure you that it's not dementia, which is generally what the story is. But always seek help if you're concerned, because sometimes anxiety can exacerbate cognitive symptoms. And so if you're sitting there with anxiety, it's better to go and speak to someone and manage that as best you can.
Thank you so much for all of that information around the science. Excellent and some practical strategies. Now, Nicole, you're a GP, as we know, and you co-founded Metluma, which provides, a pretty comprehensive solution for women looking at their physical, mental, lifestyle and hormonal health. What are you seeing the most of, like at the coalface? What's happening?
Thanks, Kim. How amazing is this? Thanks, Carolyn. That was wonderful. Thank you to Deloitte for hosting and starting conversations. I think, we've spoken a lot to it already. You used the word sandwich generation. People often identify perimenopause and menopause with hot flushes, but we know it's so much bigger than that. And certainly at the coalface, that's not what I see walking through the door. I see women in their late 30s, mid 40s, in the sandwich generation, parenting up to ageing parents. They've either got young children or teenage children, and they're working. So I don't put that like that because it may not be necessarily paid work, but doing a lot of work and trying to juggle all the tabs and all the plates. So at Metluma, we break the symptoms into 3 broad groups. What I see walking through the door frequently is a change in menstrual cycle. So either more frequent menstrual bleeding or heavy menstrual bleeding. Bloating and weight gain is a common one. Joint pain is often one that people don't identify with perimenopause and menopause. Changes in dry hair, dry skin, palpitations, fatigue. There's a range of physical symptoms that can go on. And to Carolyn's point, it's really important that we don't just sweep everything under the menopause umbrella. It's important that we take a detailed history and collect data to make sure that there is nothing else going on, like your iron isn't low and your B12 is not low, that's contributing to brain fog. Carolyn spoke really wonderfully to the mental health impact, and I think that's probably the majority of what walks through my door. I see anxiety, I see rage, I see everyone's an a-hole, I see irritability, I see I can't stand my husband, he's breathing next to me.
You get a lot of women nodding in the room.
Do I have early onset dementia? These are the questions of, do I have ADHD? And I think Carolyn really wonderfully explained the 2 kind of lanes of ADHD. It's often a undiagnosed ADHD since a child, and they've just kept it together. And then the hormonal changes in conjunction with everything else going on means that the coping strategies get a lot more wobbly. Or it is that there's so many plates open and the hormonal, so many tabs open, the hormonal strategies then, the hormonal changes then make the strategies get a little bit wobbly. So, the mental health impact of perimenopause and menopause is really something I'm passionate about. If they're if you've had a history of anxiety and depression in the past, then you're more likely to struggle with perimenopause and menopause depression. If you've had a history of postnatal depression, you're more likely to struggle with perimenopause and menopause. Sadly, the completed suicide rate is the highest for women in Australia aged between 45 and 54. So, you know, we have to be talking about the mental health impacts of perimenopause and menopause. And just to go back like a whole step in terms of nomenclature, just so that everyone understands the 101. So menopause is 1 day in a woman's life. It's exactly 12 months after her last menstrual period. And for most women in Australia, that will be around the age of 51. It doesn't take into account surgical menopause or medical menopause or pregnancy or ovarian insufficiency, which, you know, can thrust you into menopause earlier under the age of 45 quite quickly. So that's a whole different conversation. But there's, as Carolyn said, there's this fluctuation of estrogen over a period of time due to irregular ovulation and the triggers coming from the pituitaries to the ovaries that keeps our cycle quite regular. And that can happen for up to 4 to 10 years beforehand. So in Middle Eastern and Southeast Asian populations, the average age of menopause is 47, 48. So if you're talking 4 to 10 years, you know, we need to be having these conversations with women in their late 30s, in their early 40s, around, you know, changes in estrogen affecting a whole range of symptoms. And then we get to the symptoms that people often don't speak about, you know, vaginal irritation, low libido, impact on relationships, painful intercourse, recurrent UTIs. So you can see that it's a lot, and it's a lot for a GP just to unpack in a 6 to 8 to 12 minute consultation, which is why we built Metluma, so that we can take a kind of broad brush holistic approach. And then when you take into account that sleep disturbance will affect food choices, which will affect movement, which will affect, you know, weight gain, it's got to be personalised for everyone.
It's a lot to unpack. I mean, a lot of peak. Yeah, I know. I was sitting there going, yes, as well. Completely get it. And I guess, you know, we are focusing very much today around that mental health aspect, and that perhaps not even just the misdiagnosis, but actually the relief or the fear I think women feel about talking about the cognition piece, or feeling low in mood, or worrying that they're depressed. You know, what are some of the practical strategies that people can think about? Obviously see their doctor, but, you know, we know some of the stuff around sleep and exercise, but are there other things that we should be considering? And it's also, I guess, I find a bit of a lucky dip when you do go to your a doctor, because doctors have a lot to learn. I have a sister who's a GP, and it's a lot to do, as you say, in a six minute session. How do you find a good doctor? I mean, you've talked about Metluma, but what are some of the questions then I think you should be asking your doctor about, and particularly if you are experiencing anything to do with your mental health, that can help you unpack whether that is a HRT related menopause thing, or whether it actually, you know, is genuinely something that's clinical and requires an antidepressant. So lots of questions there.
No, it's a great question. And, you know, there are some circumstances, say if you've had a long history of anxiety and depression, where an SSRI might well be the appropriate medication. So we've devised the UMA-40. So the UMA-40 is a blend of what we call the green climacteric scale, which is, God forbid, developed in 1974 around menopausal symptoms. So we've adapted that and worked very closely with Carolyn and Professor Jayashri Kulkarni at the Her Centre to incorporate the MenOD. So the MenOD is a specific screening tool for menopause depression. As Carolyn said, it can prevent a little bit differently, off-on, a little bit more rage, a little bit more irritability. Sleep disturbance can be really quite significant, independent of the hot flushing. Yeah. So I think first and foremost, understand your own symptoms. So certainly taking the UMA-40 is one way to understand the physical impacts, and then we'll separate out a separate MenOD score so that you can see if what your load is. You know, we've worked with an organisation just recently, and 45% of their women had a high symptom load that came to us, you know, which is really quite significant. A large significant amount had a high MenOD load. So I think just understanding the impact on yourself is first and foremost most important. And then once you've got that information, you can then take that to a doctor to say, look, this is how it's looking for me, because that kind of distills the important bits down for the GP. I mean, you're right, women are very busy. It's very hard to find time to advocate for yourself. You know, you might go once or twice and then, you know, it's really difficult. So, you know, Metluma's here. The Australian Menopause Society has a list of doctors that are trained in and have a special interest in menopause. So as GPs, we need to know everything about everything, and we're showing up in a system, as I said, where, you know, to make money, it's 6 to 12-minute consultations. Everything across the health board is getting more complex, particularly after COVID. There is a workforce shortage. So, you know, it is hard to find kind of the needle in the haystack. So look at those two resources to finding the doctor. And then if you can go with kind of a succinct summary of this is what's going on for me, and, you know, my depressive symptoms look a little different and they're definitely cyclical and they've changed a little bit, you know, in the last couple of years. I think, you know, hormone replacement therapy or menopause hormonal therapy, which has shown a world of benefits and very small risks now, needs to be put on the table as a treatment option. And, you know, if your GP is not open to that, you kind of got to fight to, you know, to find someone. Her centre have just released an amazing study where they put menopause hormonal therapy on the table for perimenopause and menopause depression, and showed an improvement in 60% of women. So, you know, the literature is not there yet, because even in the academic world, we're still developing that, because the Women's Health Initiative study in the early 2000s, you know, blew everything up. But these guys are doing a great job in, you know, and lots of other people in getting improved literature out there on how to identify and treat perimenopause mental health better.
Thank you. And that's so true around that. The Women's Health Initiative study did create a lot of a lot of confusion and a lot of distrust, I think, around hormone replacement therapy, and yet we're seeing such benefits, not just for cognitive function, but for symptoms, for bone health, for cardiovascular, for, you know, dementia. I think there's a lot to unpack there. That's a whole other session, by the way, we can do. Thank you for that. Mel, I'm going to come to you now, because we are here talking about what organisations can do. We're talking about leadership and people, women who are in senior positions, and what it's like perhaps if they've experienced that, but actually how do they lead their organisations. We've had Karen and Deloitte have done a wonderful job here as well. But I'd like to just ask you a little bit about, you know, how sharing stories from senior women like yourself, alongside what our experts say, really helps to break down stigma and gets talking more openly and positively about menopause at work. You know, what's your experience of that?
Thank you. I must say, I'll add, and maybe it's a separate session, but there's a big generational piece here, because I was having a very lively debate with my mother yesterday about treatments, and unfortunately she does hold on to the fact that, well, an argument that it's linked to increased breast cancer. So I'll be pointing her to the link after this session. I think for me, I was really surprised. I think just the sheer relief and the connection that came from just simply sharing. And I've been one, as you said in the introduction, I've always been a strong advocate, and that's come from lived experience too in terms of mental health. And I'm very positive about that, because I feel that it's built a level of resilience in me and self-regulation that I've always carried through in my professional experience and role, and my personal life as well. But I think, you know, coming into the menopause piece, I got very lucky. I was very lucky in the sense that, you know, I had 2 children, and you know, I am one of the lucky ones. And so for me, I really wasn't in the frame of thinking I was hitting another, you know, hurdle, but what is really a very normal, I guess, universal transition that we all go through. So again, like you, I was, you know, would have these like, oh, mum, seriously. But now I sort of have a lot more understanding. And I think when I participated I was fortunate enough to be introduced to Georgie Jury and Dr. Nick here, and as co-founders at Metluma. So I do have to acknowledge my bias there. But I was introduced and participated in one of their pilot programs. And for me, coming together, a very diverse group, was very reassuring. And I, again, was going down a rabbit hole of thinking, you know, why am I not, you know, reacting in the usual way. I've been always very active, very sports focused, love outdoors. Many people in this audience would understand that. And I couldn't really understand it all. And then I think it's the first couple of sessions where people were sharing their experiences, I was like, oh, so it was a bit of a light bulb moment. And I think that's, that was incredibly important. And I think what happened then during those conversations and that pilot was really the honesty started to replace the stigma. So if I look at broader mental health, I think, we've gone through that, and we've argued to say we're still not as where we needs to be. But that really, it confirmed to me that sharing really does help to replace some of the stigma associated with that, and understanding it all and understanding people's experiences helps to replace silence. And I think that is incredibly important. If I shift to then what I'll call my day job, I do think from a leader's perspective, you do need to walk the talk, and the conversation needs to come, top down, bottom up. We've got some great storytellers within this organisation at Deloitte, and so it's been really refreshing to hear people talk about their own experiences. But I think for me, the shift really happened to understand where people were on this shared journey, in a shared place, where they felt safe, and also, people that know me well will know that I always champion the use of laughter and self-deprecation, and there are many times in business meetings I use it as a tool. Oh, I can't remember saying that, sorry. I don't think it's all negative. I was in London for a month, and people would put that down to jet lag, and I absolutely knew it was a bit of brain fog. But it was an opportunity just to pause and a bit of self-regulation, and I can't remember saying that, or I forgot what I was going to say, or that's curious. So introducing particular techniques in your own communication, that doesn't mean that you're feeling that you've let the team down, or you've said something that you're not happy with. But I think it's that awareness of what it is to recognise some of those triggers, hot flushes, not paying attention. Sometimes, it's just boredom, really. But I think in all seriousness, I think there is an element of belonging which came about, and that came through my introduction to Metluma. And I think the other thing, as I said, I didn't really have a GP. I'm one of those people. I just never had any reason. Now, obviously, I'm 53, and I say that just, and there'll be usual tests that we need to do, and I understand that increase more and more. I've always been relatively fit, so not having a GP, I think it was a positive and negative, because it made the Metluma experience really understand how I was operating, and then I got blessed, to meet Dr. Nick here. So rest is history. So I think that's
You on that safety piece, how do we translate into a workplace that sense of belonging that you mentioned you felt in that group of women? How do we kind of create a workplace where women start to feel a safe space? I know Deloitte has a cafe, the women's cafe, is that right?
Yeah, it's in group coaching.
Group coaching. How do we create that in workplaces, recognising that it's, many big organisations have the resources to do this, but many small organisations, we're a not-for-profit for four of us. We're all some of us are a bit older than the rest of my team, but we're all heading into that space. How do we kind of create those safe spaces for, low-paid areas, small businesses? What do we need to think about? And I'm going to ask all of you that question.
Well, I've always taken the view that it's not a female issue. This is in the business world. It's a leadership, challenge and opportunity. We've got also the comment I would make is we've got 2, which is great, but I'm hoping we've got 500 males online. But with AMP and Abundium in the room, I think it's really important from an inclusive perspective. And if I think about a little bit like the repeat that happens when, women have families or, and they decide to opt out because they're not feeling they're operating at a certain level. I think we have to work really hard to come at it from a whole leadership piece. So it's not a women's issue. And I think we need to really understand and I'd be able to identify and to respond to when we do see people volunteer to, you know, to sort of step back and try to sort of, you know, really help the education, help the tools, provide the support, normalise it. And I think that's on leaders in which to do that. And I don't think females can do it on their own. It's a bit like I have a very strong, as I was mentioning to some of you earlier, the old cupcake movement really upset me from a long, and I'm still of that view. That's wonderful, but I think we need to put this in the water of all of our organisations. And I was having a chat to AMP, you know, the head of the CFO is here. I'm sure he would prefer that to help his bell curve and his retention piece be, you know, really focused on having that diversity of thought, the talent that we actually do identify, develop, and then we lose. So I do think there's a real call here for corporate Australia to really step up to the plate to bring this into not just the leadership forum, but also through the policies and the governance in which organisations look at. And we've started to do that through mental health. We can't look at this in isolation, would be my tip. So, yeah, this is very much a call for leaders to stand up to the job.
No.
What are you seeing in terms of strategies, things that work, what's effective?
Look, Mel and I didn't rehearse this, but I'm going to, I'm going to sing from the same hymn sheet. The mental health piece is something I get really passionate about. And the fact that this is a societal issue is, I also get, this is not a women's issue. We all have women in our lives we love, we care for, we work with. We have to be showing up for them in order to create safe spaces. So safe spaces is the biggest one. I mean, mostly what I see is what Mel said, you know, as soon as a safe space was created to have a conversation, then that in its own right can be therapeutic. Butterfly effects from those safe spaces where women are then sharing story, and it doesn't necessarily mean around problem solving. You know, I would say seek to understand. We work with a range of organisations, and the lived experience of the field worker in PPE, you know, in PPE versus the teacher who's got recurrent UTIs in a flooding period versus someone in a air-conditioned office. You know, let's not get into air conditioning. It's all very different. So you know, knowledge is power. Understand the general language and impact on women, but also seek to understand their personal experience. You know, create a space where the conversation can be had. What are the solutions? Well, we're building them, right? If someone is suffering, you know, they have to seek medical care. It's amazing to have shared spaces and policy, but if someone is suffering, they must seek medical care. You know, so point them in the right direction of where that might be, you know, and you know, walk alongside them. As we know, you know, my tagline is menopause is not a boot camp. You don't show up and take your hormones and everything's fixed. You know, this is a journey for women that will last 4, 10, 15, 20 years. You know, we want to be reducing the risk of dementia, reducing the risk of cardiovascular disease and stroke and hip fractures. So we want to be journeying alongside you in a tribe and community to do this well.
Carolyn, was there anything you wanted to add? Carolyn, anything to add to that?
I guess I'll just echo as well what Mel and Nicole said, that I think having conversations is such a great starting place. It's really, really sad when we see people who have left the workforce because they felt and suffered in silence and alone because they felt they suddenly weren't up to it. And you know that if they got the right support, that they would have been fine and they would have continued on and had you know, great journey in the workplace. So I think, yeah, conversations to start and encouraging people to seek the right support so that they can do their best to thrive. And I guess I always also like to add that midlife for everyone is also a time to think about healthy brain aging. And while we're talking about mental well-being, it really is the perfect time for everyone to, while it's a time of vulnerability for a lot of people, it's also a time of opportunity to really reflect and build brain health. And everything that's good for the heart is good for the brain. So I think everyone knows all the tips of making sure people exercise and eat well and sleep well and address any sort of mental health concerns, because all of these things are super important for ensuring people have good, healthy aging and can kind of maximize their ability to thrive at work and at life in general. So I think, I guess that's another point that I wanted to add.
Can I have one tiny point? Sorry, I do.
Of course.
Okay, thanks. And I'm just going to come back to, I think people, you mentioned it, Dr. Nick, about people's experience. So I consider myself, I got off lightly. I think but then there's people that are really, really suffer.
Mm-hmm.
And I think from a leader perspective, but also from a friend or a daughter perspective, I feel that, I've tried to flick that guilt switch. So I used to feel very guilty about, I seem to get, I'm okay. There's a few things that I need to do. So which probably made me withdraw a little bit more. So I've tried to replace feeling guilty with more empathy and understanding. And I think that is really key too, because again, I'm wanting to work with a very diverse, team, and it's wonderful, capability that I, in my teams or across the firm or in the market, whatever it might be. So I think it's also feeling comfortable, even though you do find your group to share. I think it's also to challenge yourself too, because there is so much to learn from when the experience is not mirrored by your own. I think that's.
Can I ask on that though too, just picking up on that point, not everybody feels comfortable sharing their experiences. And we know that with organisations, some women are very private and they want to keep it private. They don't want to talk about this aspect. How do we kind of, and go back to that, find the language that we can use for men to use to ask questions in the office, and how do we talk about keeping people at work? Because I think I spoke to someone earlier where they'd been speaking to someone who was going to leave their job in a senior position, but has now been able to manage that. And just to hear that someone stayed in the workforce that thought they had to leave, how do we find a language to help women who don't want to talk about it, but equally for men to have the language as well that's kind of not, a negative? Because I'm worried about sometimes when we talk about menopause, we see it as a deficit or there's something wrong with women, and it's actually a natural thing. So how do we kind of come from a positive strengths-based approach? Any tips, any advice?
You want to take that?
Oh, give it a go. No, you go first.
All of you.
Well, I'm at the coalface in general practice, so I'm just going to call out. I don't have necessarily lived experience in this space, but I think to speak to your point around strengths-based, I think it's important, because I guess what I see is women can lose a sense of themselves. There can be guilt, there can be shame, there can be low self-esteem, loss of confidence. So certainly leaning into that conversation that comes more from a strengths base, I would say, is really important. So as tip number one, and then speaking from the I, again, seeking to understand and not to presume what the experience is, because it might be perimenopause or menopause, it might be something else. I have noticed this, or, from my experience. So I mean, when I have awkward conversations, I often call out awkward conversations. I often say, look, I'm about to lean into an awkward conversation because I really care about you, and I may F the language up and I may stumble over my words, but, I really want to seek to understand your experience here so we can work together on how we can, start to problem solve it. And sometimes, I feel women know how to heal women best, and sometimes they don't necessarily need a solution. They just need a validation or an acknowledgement.
Which men generally sometimes go to solution mode.
Yes, which is great too.
Yeah.
But yeah, it's just finding that different, finding the shared agenda.
Yeah.
So Nick's good at awkward conversations, because now I eat fish with more bones.
That's right.
Because again, not to do with mental health, but yeah. But in terms of my, from a bone perspective and where I am in terms of 53, some things I just didn't know. So I guess segue to data, and also if you break it down to certain modules. So for me, sleep was a big one, which again, it's not as maybe challenging, or people don't get too oversensitized, because there's all different reasons why, and there's all different tools as to how to actually help. So I think the module piece is really good, because if you look at it, overall, it can be pretty overwhelming. So I think breaking it down is, and then you find your entries or your topics that you are comfortable to share a little bit more than others. So it might be you have certain tactics or certain techniques that have helped you from a sleep perspective. So I think it's, and again, I'll reinforce the fact that more men, more to normalise the conversation is absolutely key. So we have, you know, the storytelling is incredibly powerful, as it was when we first started the Alliance. And I will say, I think the other piece, and again, I've always had a long association with the Alliance and former board member, but I think what the Alliance does in terms of sharing information, distributing that as far and wide as possible, making it accessible, I think that is on corporate Australia in terms of their responsibility to the broader community, and we need to take that seriously.
Is there anything you wanted to add?
I think it just not always forcing people to have conversations, because as you mentioned, not everyone always feels comfortable, but knowing that these are very normal experiences and shared by so many people. So I think, yeah, having conversations, sometimes people just hearing them, they might not actively participate or voice their own experiences, but just hearing it can be comfortable for people. And as we mentioned earlier, just knowing there's a safe space. So if there are senior leaders in the room who don't know how to approach these conversations, just acknowledging that there is a safe place there for people to talk about any supports they need, and acknowledging that it doesn't define a person just because they might have one symptom or struggling in one area. People still maintain all of the skills and strengths that they previously had, but they might be experiencing a particular symptom characteristic experience that, you know, might be time limited and might need support, but that doesn't diminish a lot of other skills. So it's just, I guess, encouraging people to seek some sort of support to help that particular area that they might be struggling with, but acknowledging that all of the other skills that that person might have are still there. They don't necessarily disappear. So yeah, that's all.
Can I add to a little bit? Sorry.
She fell.
Yeah, sorry.
Please do.
It's just going to comment on the data point too. There are a number of people, and I know many in this room, and I'm sure virtually, that carry, you know, people, HR, D&I roles. The work that they do is incredibly important to shine a light up to the executive and elsewhere, and to our own people, to normalise this and to demonstrate some of the things that are available and that actually benefit and work. And there are plenty of people that are happy to put their hand up and say, with their consent, to share their story around that. But I think the data piece, and I know because I've worked closely all my career with very talented people, many in the room, and I see Kate at the back in terms from a Deloitte perspective, that do a lot in this space from a, you know, an annualised performance, talent, leadership, development perspective. And I think those individuals with their skill set can be really important in this narrative.
Can I just pick up on that point about retention, and also just that you know, HR roles and etc. You know, what are some of the things that, you know, people should be asking for? Not should be, you know, how do we create an avenue for conversations to ask for sometimes what might be a reasonable adjustment, or a way in which to say, I'm struggling with this at the moment, and we have those conversations with HR as you would with anything else. We do this with mental health. How do we open up that conversation around menopause? Is there something that we can do around improving access to support? Internally, we have resources and policies, but equally that next step of how do we, you know, do that bridge from workplace to actual access to care? Any sort of your opinion, Mel, just working in the corporate world around that, and then any other practical examples?
Well, I think if I look at it from a geography perspective, I think there are you know, the UK and elsewhere are doing some great work to attach it to broader policies from an equality perspective, even into, you know, anti-discrimination. And I think given how they're established within organisations, you can accelerate a better outcome by leaning on or engaging in that framework. So I think that's always really important, because I think if you do it in isolation, it's very, very difficult to move the needle. I think having an ambassador, and many of them, again, is key at all levels in the organisation, and to actually, to really be open to learning. For me, it's been quite a learning experience for me, but I'm also learning from younger generations that are far more comfortable and probably advanced in seeking help for certain things. And that is not the generation that I grew up with. It was, stiff upper lip and soldier on and you'll be okay. And so I think that, again, around your own openness as a leader, particularly when you are responsible and it's a privilege to be around those tables, I do think you have to constantly remind you to tap in that younger leadership, or those more junior individuals, or early careers, as we would call them at the Alliance, to help inform us what is going to be appropriate for a future workforce. And particularly when, let's not get us started, but when agentic and everything, and we're competing with robots that don't sleep and don't need anything. And so, there's a lot of stress, but I think actually tapping into that is incredibly important to inform not just what's suitable for the workforce now, but what's going to be beneficial for the workforce going forward. Yeah. And the Alliance, spread your material.
Does Carolyn?
Carolyn,
Go next.
anything?
I'm just trying to think if we've got anything to add. I don't know whether we've got anything to add to those things. I completely agree with everything that's been said so far. And yeah, I don't really have anything insightful to add at this point.
Nicole? Yeah, pretty similar. I think Mel summed it up nicely, but it has to have a D&I lens on it. So just having an awareness around that. And I would say that in terms of the work we've been doing, successful organisations have many champions. They must have a champion, and that the champions will be in there for sure. There are so many people with a loved one that's had a difficult experience, or a personal difficult experience, or some kind of usually personalised experience that is passionate around finding some solutions within an organisation.
Well, we're just at time. Got a couple of minutes. Perhaps I can open up to any questions. Got time for a question, Hannah?
There's lots of individual questions, but I suggest they reach out to Metluma.
Oh, okay.
But there is one question. Does menopause actually end, or do some symptoms always remain? That was a good one. That's great. Let me just repeat that. Yeah, repeat that in the microphone.
Yeah, so the question is, does menopause ever end? So theoretically it's one day, so yes, that day will end. But in terms of your symptoms, yes. So we find that the symptomatology will often peak in the kind of 12 to 18 months at its highest coming into that menopausal day. And then after the menopause day, the body finds a new equilibrium in the lower hormonal state. Now, having said that, some symptoms can persist. So some women will continue to hot flush into their 60s. The dryness ones are often ones that do persist: dry eyes, dry hair, dry vagina. Sometimes the other symptoms will persist, but for the most part, they will settle down. But for those who are still experiencing symptoms into their 60s and 70s, the Women's Health Initiative said stop MHT after 5 years. That's not the case anymore. It's now basically a personalised discussion around a risk-benefit ratio, because the literature is still coming out for kind of starting MHT for women in their 60s and the risk benefits, but it's not a hard no anymore.
Any questions in the room? No one. Well, I'm sure we can chat to Nicole and Dr. Nick and Mel as well. One quick takeaway for the wrapping up our session. One thing you think as a key takeaway for those listening here and online.
Do your UMA 40. Get all your loved ones and everyone around you to understand your symptom load.
I think be curious about self and about others.
Carolyn?
Yeah, and I agree, monitor, check in with yourself and seek help. There is so much help and support out there. So don't sit there and suffer and feel awful about whatever people may be going through. So seek help and do your best to thrive as much as you can during that phase of life.
Thank you so much. We are going to send out a little resource next week and a copy of the recording for anyone else who wasn't able to make it, who registered for today. But thank you to our wonderful panel. Round of applause for everyone. There are so many more discussions to have out of this. I've got a million questions. So, but thank you to everyone for attending today. It's an hour out of your day, and I hope that you walked away with something to take away with you, that you might have learned something new. So thank you.
Thank you.